All right, I think we are good to go.
Okay, great. So, Reha, if you want to start.
Hello, everyone. Today I'll be speaking about a procedure that we've been doing for the last year as part of the comprehensive CTEPH treatment center. We perform percutaneous balloon angioplasty of pulmonary arteries in patients who have chronic PE leading to pulmonary hypertension with my partner in crime, Behnam Tehrani. So PE is a very common disease. We see it on a daily basis at the hospital, and we treat a lot of the patients either with anticoagulation or more invasive methods. About 30 to 50% of these patients come with submassive or massive PE, meaning there's so much clot in the lungs that the heart is under strain and it's trying to pump the blood into the lungs and is having trouble. So some of these patients long-term develop CTEPH, and the rate is about 0.5 to 3 to 4%. And some patients present with CTEPH with no known history of prior PE. But CTEPH is a very complex multifactorial disease, and it has some of it is related to the clot burden, but a lot of it is related to the inflammation and abnormal fibrinolysis. You know, not everyone who has a lot of clot or submassive or massive PE develops CTEPH. So there's a big component of small vessel disease and abnormal fibrinolysis in these patients. You know, it happens because of incomplete resolution of the clot in the lungs, and the pulmonary arteries over time have a lot of inflammation. It causes scarring and fibrosis and narrowing, and that leads to pulmonary hypertension. So this is a natural progression of CTEPH. You get acute or recurrent pulmonary arteries thromboembolism. The clot over time organizes, does not dissolve completely. This leads to slow blood flow in the vessels, and that leads to increased peripheral vascular resistance and abnormal remodeling and pulmonary hypertension. So the diagnosis of CTEPH, there are two components. One is the chronic clot in the lungs causing fibrosis and scarring, and the resultant pulmonary hypertension. So these are the main two components. And how do we diagnose this? Well, first, patients come with some clinical symptoms. They get shortness of breath, they have exercise intolerance, and they have either known or unknown history of PE in the past. And what we do is we get an echo 3 to 6 months after the initial event that shows right heart pressure increase. Then we get a VQ scan or a dual energy CT scan, which shows peripheral clot narrowing in the vessels and enlargement of the central pulmonary arteries. And if you see perfusion defects in the lungs on the VQ scan 3 to 6 months out after the pulmonary embolism event, then the perfusion is still abnormal in the lungs, and you come to a diagnosis. But the gold standard is right heart catheterization, getting hemodynamic pressure across the heart chambers, along with selective pulmonary angiogram. This image, for example, the pulmonary artery is huge when you compare it to the adjacent aorta. That shows you that there's pulmonary hypertension. And you can see here, the clot is more peripheral. It's not in the center, like where you see in the saddle embolus. It's more peripheral, and there's even some calcium in that clot. So this shows you that this is chronic PE. This is more acute presentation, for example. You can see the clot is kind of central in the vessels, but over time, the central clot resolves and moves to the periphery of the vessel and causes scarring. So that's kind of what it looks like long-term. And this, on the left-hand side, we have a coronal image from a dual energy CT. Dual energy CT is a new method that we've been using. It gives us anatomical information. It shows us the vessels really well, but on top of that, it gives us the information of physiological information, the information we get on perfusion scans. What it does is it applies 2 levels of energy and subtracts that based on the ionic uptake of the tissues, and draws a map of how much perfusion the lung is getting. So the blue areas are areas where it depends on how you color map it, but the blue areas in this image are the areas that are getting low perfusion, and the red areas are the normal areas. Here, if you look at the right interlobar artery, you can see there's clot at each side of that vessel. So either do a ventilation perfusion scan or a dual energy CT scan, and that shows us perfusion defects. And then we proceed with a right heart catheterization, and we look at the vessels in more detail to more of the distal vessels, as opposed to more central vessels with the CT scan. And then we have a multidisciplinary team, and then we decide on the best treatment option. So the Riociguat is a vasodilator and the only approved medication that we use for treatment of CTEPH. But I'm not going to go into detail about this because everyone on this conference call probably knows more about the medical treatment. But it was shown in the chest trials to improve PVRs and 6-minute walk test performance. So there are some other adjunctive medical treatments that we use as well, but the main medication is Riociguat. Pulmonary endarterectomy. Dr. Tang is on the conference call with us. He performs the endarterectomies. We are at 4 or 3, Dan? We're at 4. Okay, so we've so far performed 4 endarterectomies in the last year. And this is the standard of care, gold standard treatment for CTEPH. This is a deadly disease. Not only does it affect the quality of life of our patients significantly, but it also carries a 50% survival rate at 5 years. So that's pretty similar to a lot of metastatic malignancies. If the patient is an operative candidate, we prefer doing pulmonary endarterectomy. Because you can really get out that, you could carve out, so to speak, the fibrotic material from the vessels and really relieve the pressure. But it's a big procedure. It involves hypothermic circulatory arrest. And, so not every patient is an operative candidate for this. In high volume centers, the success rate is high. And so far, the 4 that we've done, we've had great success in the hands of Dr. Tang. And so so that's our mainstay treatment, but it's preferred for more central clot. If the clot is more in the segmental or subsegmental areas, which is the level 3 and level 4, the operation becomes a little more complicated. So this is what it looks like on a histopathological specimen. This is the vessel, and you can see all this fibrous intimal hyperplasia with a lot of collagen deposits, and you can see these microchannels that form in the vessel. But compared to the vessel lumen, these are really, really small. And this is what we're dealing with. The blood flow tries to go through these microchannels through the diseased vessel. Balloon pulmonary angioplasty is an alternative treatment to pulmonary endarterectomy. Both have their own roles, of course, but it involves percutaneous balloon angioplasty of the diseased vessels in the lungs. We go through the groin and we place the balloon into the diseased vessel and try to open it up. We're not getting rid of the fibrotic material, but we're creating larger channels in the diseased vessels to provide blood flow to reduce the pressure load and the vascular resistance. The first study came out in 1988. They showed improvement of the pressures. However, the complication rate was unacceptably high. And then Dr. Feinstein did another study in 2001. He studied 18 patients. This was done in Boston, and he performed 2 to 3 sessions on each patient. They again showed improvement in the pressures and functional capacity, but 11 of the 18 patients had major complications, ranging from bleeding to requiring intubation. Here you can see from A, B, C, D, E, and F, like subsequent after each subsequent treatment, the vessels are better defined. You can see the subsegmental branching compared to A to F. These were like after several sessions, you can see the improvement in the blood flow in the left lower lobe. But after this report, the procedure was abandoned for a long time because of the unacceptably high complication rates. You can see what we do when we do balloon angioplasty is you can see that dissection plane. We kind of extend that dissection and try to open up the vessel a little more. And after that initial report, the procedure underwent some refinement. As opposed to using bigger balloons to size the vessel diameter, we started using smaller balloons and we started staging the procedure more. We started, initially they were doing these with 6-7 millimeter balloons, and now we start with 2 millimeter balloons, then gradually advance the balloon diameters. And we've noticed that the complication rate is much, much less with this method. And now it's considered an alternative procedure who are not operative candidates. there are subsequent patient registries and a significant portion coming from Japan that showed improved functional tests and reductions in the pulmonary pressures in those that have had BPA. You can see one of the registry was 308 patients. These were all done in later 2000s. And the results are also sustained. So they study these patients up to 3.5 and 5 years. And the PVRs, the cardiac index, and the mean pressure were all improved. But more importantly, they were sustained improvements, and they stayed that way. So this is a study comparing BPA to pulmonary endarterectomy. And this is an apples to oranges comparison because, one, the BPA patients usually tend to be more inoperative, not operative candidates, and their lesion characteristics tend to be more distal. And the patients who undergo endarterectomy have more central disease and are in better functional status. But when you compare the two, the safety and efficacy is similar. Maybe there's a little bit of increased infection rate with the pulmonary endarterectomy and a little more hemoptysis with balloon pulmonary angioplasty. And here you can see the complication rates. It's pretty similar. One more death in the PEA section, PEA population compared to BPA. And this study followed 30 patients after BPA, and they performed pre and post functional MRI studies. These are after each session, the functional MRI was repeated. And along with improved hemodynamics, the patients had remodeling of their chambers, and they have improved biventricular function and pulmonary flow. Their acceleration time and ejection time was all improved. You can see the right ventricle has gotten significantly smaller compared to the initial treatment. This is a study that showed the troponin and BNP levels following BPA to be lower, which are other indicators of right heart strain. This is the pulmonary angiogram. You can see the segmental anatomy. We're dealing with 10 segments on each lung. So that's 20 segments in total. And we try to get into each, the major subsegmental branches. So we're dealing with probably selecting 50, close to 50 vessels. And we do this in a gradual, staged fashion. And we start with 2 millimeter balloons and go up to 4 to 6 millimeter balloons. So that's a lot of procedure time. And meanwhile, the patients are under only local sedation, and we have to control their breathing. And every case takes about 2 to 3 hours, but it requires a lot of patience, both from the operator standpoint and from the patient standpoint. So the pulmonary angiogram is the gold standard for the diagnosis. It gives a very good detail of the peripheral lesions that are not otherwise well seen with the CT angiograms. And we also do the crucial hemodynamic assessment of the right ventricle, the right atrium, and the pulmonary arteries when we're across the chambers before we start the angiograms. These are some sample images. In image A, you can see the so-called pouch defect. Normally you should see the vessels branch out like this and slowly taper from large to small. But here, the discrepancy between the interlobar artery and the segmental branch is huge. And it slowly tapers, and the vessels do not go to the periphery of the lung, to the pleural surface. So this is clearly abnormal, and the interlobar artery abruptly ends. In image B, you can see, and this is a very early phase, you can see irregular clot kind of filling that vessel. But if you wait a little more delayed, you're not going to see that. But that's the so-called pouch defect also. And here you can see the ring defect, so that's a very significant tight stenosis in the left lower lobe artery there. And here there's an image of the PA view and the lateral view. If you only do one view, you could say, okay, this looks normal. The only caveat would be, okay, the vessels maybe are not going to the very periphery of the pleura, but you don't see any abnormal vessels. Well, if you do the lateral view on the same lung, you're going to see that this whole lower lobe is absent. So that is the nubbin of that segmental branch, in segment 9 and 10, that's completely absent. And you see no flow in that corresponding lung. So this is the most commonly used vessel disease classification system. And we use this classification as well to determine what lesions would be best to treat and what lesions would have the less complication rate. These are the lesions we try to target with balloon pulmonary angioplasty, the ring lesion and the web lesion, the web being the most ideal. The ring is slightly more tight, and the web essentially has like intraluminal areas of webs and narrowings. The ring has affected the adventitia of the vessel, and it's really tight. Both of them respond okay. This is subtotal occlusion. You get a little bit of trickle of flow beyond the occluded segment, and total occlusion, like the one I saw show you last image, where there's absolutely no flow beyond the occlusion. And the last segment, the last classification is a tortuous vessel. These are really disease abnormal vessels that don't follow the straight course, and they have a very tortuous pattern. And the theory is that maybe these are not even the actual vessels, but they're collaterals that develop over time. This is really rare. So mainly we target the ring and web lesions and try not to touch the subtotal and total lesions. This is an angiogram showing a variety of lesions. You see a subtotal occlusion here in the right middle lobe, and you see the wedge-shaped defect. So there's a big perfusion defect. You should see this is a more delayed parenchymal phase, and you should see the parenchyma as you see in the upper lobe and the lower lobe, but we don't see that. You don't also see the medial aspect of the right lower lobe, and those are big perfusion defects. And here you can see the ring lesions, the web lesions, and total occlusion. So you can see all of these lesions in a single angiogram. And these two are conventional angiograms, and this is a CT angiogram. I wanted to show you this because on the conventional angiogram, you could completely miss the findings. There's some irregularity in the right interlobar artery, but and then on the more delayed phase, you can see big areas of perfusion defects in the left upper lobe, the right upper lobe and the left lower lobe. But if you look at the CT, you can see there's so much clot along the periphery of the vessels. This is all chronic PE, but you don't appreciate that much on the angiogram. So the angiogram is more for distal diseases, segmental and subsegmental level, and the CT angiogram is better for more proximal disease assessment. These are some examples of the angiograms we've performed. This is a CNA image. This is what they use for cardiac exams. It doesn't have the subtraction, so you can see all the bones in the back. You can see there's a little bit clot here, and you can see a little more clot here. It's in the peripheral branching point. This is not very chronic. This is more acute, I would say. Here you can see it's kind of lodged in that branching point, subsegmental, and here it's sitting right there as well. So this is a subtraction image, and this is a non-subtracted CNA image. So this is a study that where they looked at 97 patients where they did BPA, and they classified it according to the lesion type. And the total, subtotal, total, and tortuous vessels carry the highest complication rate and the lowest success rate. And these are examples of 3 lesions that were treated with BPA. Here, pre and post, pre and post, pre and post. This is a tortuous segment, for example. They try to open it up, but here you can see the result. The vessel is really small, and they didn't get much from the treatment. Here you can see in pre and post, you got a much better vessel definition and improved flow. So the ring and web lesions respond much better to the treatment. So UCSD is one of the highest volume centers for CTEPH treatment in the country, and they do both BPA and endarterectomy at a high volume. They follow a similar method to what we do. They gather all of the information, diagnostic information. It's assessed in a multidisciplinary team, and then best treatment option is determined based on that. More central disease gets pulmonary endarterectomy if the patient is an operative candidate, and more distal disease gets BPA. And this is how they perform BPA, and we do a very similar plan with minor variations. We do the cases 1 to 2 weeks apart and perform 4 to 6 sessions for every patient. And we limit each procedure based on either the contrast volume, the radiation dose, or procedure duration. If the contrast volume has reached 150, 200 milliliters, we stop. If the radiation dose has reached 1 to 2 grays, we stopped. If the procedure duration is 2 to 3 hours, we stop. So, it's very tedious work. It requires a lot of patience, and you have to target a lot of different vessels. And the patient is breathing. Meanwhile, you're working through the lung that's moving constantly, and you're trying to get a small wire through a diseased vessel when everything is moving. So it's not very easy. We go through the groin with an 8 French sheath, and through that we use a 6 French sheath, which we park in the lungs. And through that, we use our 014 tiny wires to try to get through the vessels. And we use light sedation since we require patient cooperation with the breathing during the procedure. It takes about 2 to 3 hours. And after the procedure, we admit the patients for overnight observation. This is an example of serial dilatations they performed, initial, and then you can see post. The vessels are much better defined. Here, they used to do this very often. They don't do it anymore. They will look at the pressure gradient proximal and distal to the lesion. And after the treatment, they will gauge how aggressive they're going to be based on the pressure gradient. Here you can see this is the red one is the pre and the green one is the post-stenotic area pressure. Here you can see the gradient has substantially decreased over time. But it's very time consuming, and we don't do it. And I believe UCSD also doesn't do it as much anymore. The complications, when they first started doing BPA back in the day, a substantial amount of patients were having complications, as I've previously stated. And a lot of this was told to be reperfusion pulmonary edema. And the patients would have extensive ground glass opacities. Here you can see it, it's kind of small, but you can see extensive ground glass opacities in the lungs. This was associated with increasing oxygen requirements and hemoptysis. So the theory is you're opening up these vessels, and all of a sudden you have tons of blood flow to the lungs, and you have this reactive pulmonary edema, similar to what we see when we do recanalizations in the legs. But my sense is that more of these were related to a hemorrhage from wire or balloon injury, as opposed to reperfusion edema. And over time, they've noticed that the wires and the balloons were probably causing these, and then the procedure got refined, and now we're using atraumatic tiny wires. We're using smaller balloons, and we're being much more careful when we cross these lesions. So now the complication rate is much low. This is a complication that I hope we'll never see. This is a case that was done in Japan while we were there visiting. They try to recanalize an occluded vessel, and here you can see the contrast spilling into the pleural space through that perforated vessel. The only treatment of this once this happens is gel foam embolization of that vessel and taking that vessel out, and that's absolutely something you don't want to do. Similar to a groin line, when you're doing a venous puncture, you only hold pressure after you remove the line for maybe a minute or two, because the vein, the pressure is very low. But when you do it in an arterial line in the groin, you have to hold pressure for 10, 15, 20 minutes because the pressure is really high. Well, these patients, in normal patients, when you injure the pulmonary artery, there wouldn't be any problem. It just seals off right away. We do pulmonary angiograms all the time. But in a patient with pulmonary hypertension, the pressure is so high that if you cause an injury to the vessel, which is very diseased to begin with and very fragile, that bleeding is not going to stop. So that becomes a problem. And that's why we have to be really careful. And that's why we measure the pressure prior to doing anything to see how high the pressure is. And if it's really high, we're extra careful. And Japan in the world has the most amount of published data on BPA, and they have several centers that they do these in high volume. And they follow a similar treatment algorithm. And we follow this algorithm as well. But in practice, they tend to perform BPA a little more than endarterectomy. In the US, we perform endarterectomy a little more compared to BPA. And it's unclear whether the Japanese population has more peripheral disease as opposed to central disease. But here we tend to see a little more central disease compared to peripheral disease. So it may be a population-based thing and may be related to experience and of the surgeons there. But it is what is. In practice, they do a little more BPA. On our side, we do a little more endarterectomy. They do a very similar thing. They stage their treatment. They try to do as many segments as possible. And they start with small balloons and go up gradually. And this was the center Okayama that we visited last September 2019. This was before, of course, the COVID thing. You know, it feels like a different time. And over years, you can see their volume. They've went up to 400 sessions each year. And that's about maybe they do 4 to 6 sessions in each patient. So 80 to 100 patients every year. So they've gotten really good at this. This is an example of a patient they've done there, pre and post. You can see the vessels have really remodeled and the flow is much better. You can see their gradient here, high gradient, but now they've gotten improved over treatment sessions. And again, they use very, very light wire, and they use small balloons. They gradually increase and try to do as many as possible. In the past, when they were doing this initially, about 10 years ago, they were using intravascular ultrasound, and they were sizing the vessels based on the intravascular ultrasound. So they were matching the size of the vessel with their balloon size. Now, if you do that, you're going to have much more complications. So now we just start with a small balloon, create multiple channels in the vessel that leads to decreased pressure, and then we gradually increase from 2 millimeter to 3 and 4 and 6. But initially they were doing the true size of the vessel, and the vessels were not responding well to that. There is an example of a patient they did. Over 4 treatments, the pressure has decreased from 40, the mean pressure, to 26. And here you can see the matching diameters of the vessels. And their average population is about 63 years old, and it's a female predominant population. Their average pressure they start off with is about 42 mean of the pulmonary artery. So relatively high pressure, high PVRs, and that's their average population. Initially, from 2004 to 12, their complication rate was 12%, and now it's 0%. And we've done about 4 patients so far, and knock on wood, we haven't had any significant complications either. And since we're following their protocol. And here you can see, sustained decreases in the pressure over 5 years. PVR is also decreased. Their oxygenation is improved, and 6-minute walk test is improved in their patient population. So this is, to conclude, it's a very complex disease. It requires a lot of different fields involved, Oksana, cardiology, CT surgery, interventional cardiology, us. And, PEA still is the main definite treatment for potential curative therapy, but it's more used and works better for central vessels. For patients who are not operative candidates and have distal disease, BPA is an important alternative therapy that is a promising option and is being increasingly utilized. So that's all I got to say. Thank you so much, everyone. And now if there's any questions, I'd be happy to answer them.
Thank you. Great talk, Reha. If anyone has any questions,
if I can
ahead.
answer. If not, I'll ask Oksana herself.
I actually have a question. Do you anticipate this procedure might eventually be more than just for the inoperable patients?
If the clot is central, I don't think this procedure will work well. Okay. But if the clot is segmental and distal, even in the inoperative candidates, they use it in Japan especially, and it shows promising results. So yes, but if it's in a couple of the images that I've shown, it was the clot was very central. In those, I don't think we'll have great success.
But probably to add to that, operability applies to both surgical and medical. There are medical and surgical parts to it. So someone can be, maybe you can get to the distal part of the clot, but the patient medically is not a good candidate for surgery. So if they have a distant disease, even if it may be surgically accessible, if it's segmental or subsegmental, sometimes BPA can have a role in management of symptoms, probably with medications, combined with medications. Yeah.
Sometimes also in post-operative patients we do it, and so it's increasing, and as we get better, also we're going to do it more and more. But again, if the patient is relatively young, mostly central, I would definitely defer to Dan for treatment.
I have a question.
Yes, sir.
Another disease we see quite often is interstitial lung disease, and a lot of times these patients have complicating pulmonary hypertension. I think what is unknown is how many of them have a component of CTEPH that's contributing to their pulmonary hypertension. If you get a VQ scan in these patients, invariably it's uninterpretable. We've seen high probability VQ scans, and on a couple of occasions gone onto pulmonary angiogram and there's nothing there. How good would dual energy CT be in terms of trying to risk stratify these patients for component of CTEPH? And, should we be getting these more routinely in our ILD patients who do have complicating pulmonary hypertension?
Initially, when I was looking at these dual energy CT scans, I was a big skeptic. But as I've looked at more and more and more and more, I'm now I'm a believer. And because not only does it give the physiological information, it also, you have the anatomical information on top of it. The vessel detail that you see on those ion maps are outstanding. They're even better than a standard CTA. So you can really see the vessels to a very distal segment. And if you see abnormal vessels with the corresponding abnormal perfusion map, that gives you a very good idea. The more subsegmental vessels, you're not going to have a lot of information, but I think over time, it's going to take over VQ scans probably. Even now, I think it's so much more information because, the VQ scans, you have an idea, you say, okay, in the lower lobe somewhere, but really you don't really know what segment that is. And it's kind of very subjective in my opinion. And the dual energy CT gives you much more information, especially when it's superimposed with the anatomical vessel information.
In terms of getting the dual energy CTs, are we getting them here now, or do we still have to send them to Fairfax Radiology?
We're doing it here as well.
I think that, typically when we get CTs in the ILD patients, it's high-res CTs without contrast. Could we combine these perhaps with when we get a high-res CT for interstitial lung disease?
I don't know if I'm not really sure if you would have to scan again, I think, prior to giving contrast to do the high resolution and then do the dual energy CT. I'm not sure if you could do the high resolution CT scan as part of the dual energy CT.
Yeah, probably, but I mean, you could do it in the same setting, get the high res first, give contrast, and then do the dual energy after that.
That's correct.
I guess that's something for us to think about as a group, if we should do this, especially in the patients who we suspect have pulmonary hypertension. Okay, thanks.
Yeah, it will only take 1 minute to do the high resolution and then, change the settings, give the contrast to the dual energy. It shouldn't be a problem.
We're going to come up with group 3.5 pulmonary hypertension.
We definitely have patients who have interstitial lung disease, and then they have some chronic clots. We have a handful of those. So.
Yeah, we have some that we think has CTEPH that turn out to be completely normal too. So
we do. Right. Well, this is great. If anyone has any more questions, please go ahead and ask.
Reha, I think you mentioned it, but how much contrast do you give when you're doing like a full series of angios compared to like a regular pulmonary angio compared to a CT scan?
Regular CT scan uses 100 cc's. We use, we've done cases where we use only 60 to 70, but the average is probably 100, 120. It depends on the patient. Sometimes some patients are pre-treatment suspicion is very low and they have pulmonary angiogram. So we do a more non-selective angiogram. So you can really limit the contrast when when you do a non-selective one. But if you go to each individual segment and try to get good pictures on every single segment, then you're increasing the contrast probably to 120. The most we've done was 140, I believe. But in Japan, in France, they give up to 400 cc's. We've never done that.
Great. Okay, well, thank you very, very much. So this is our fourth lecture on CTEPH, and we are working on putting all four of them on InovaNet, and so that way people can look at them at their own time as well. So thank you again for joining us, and have a great rest of your week.
Thank you, everyone. Have a good evening.